Hello, everyone. Welcome to this month's Roundtable. And this month, we're going to be talking about the lumbar spine. And Chris, I'm going to jump right into you because I know you have some exciting things to talk about.
Yeah, this month I'm going to be putting up an article and a video actually talking specifically about neurogenic inhibition. And I chose this because it's something that, one, I know there is almost no research surrounding the area, but during my fellowship mentoring hours that I'm doing, it seems to be a pretty big component of what my mentor talks about and how he treats his certain spinal conditions. And so I wrote an article kind of detailing what my previous training had been with it, what this new introduction through my mentoring has shown me, and then kind of my thoughts on it, which, again, the lack of evidence for it kind of is something worth noting, I think, through the whole thought process.
Hey, for our listeners, can you tell everyone what neurogenic inhibition is? And then why do you think the research is not available for it?
So one, neurogenic inhibition is the theory that there is a so-called weakness. A weakness is not the correct technical term because weakness deals more specifically with the muscle level, but a muscle does not perform adequately due to a lack of nerve stimulation. So for example, if I were doing my glute med muscle test, the muscle test would test weak potentially because the nerve signal is not getting all the way through. That's one of the theories that are out there for it. And I go over a couple other descriptions of how that person might present in that same case. But again, there's no rule as to this is how neurogenic inhibition is. But the reason that I wanted to bring it up is because there are a lot of ways that we can actually change that same muscle test or muscle performance test with either manual treatments, exercises, just different cues that we give the patient so that it's not always going to test weak.
I think that's so cool because I know so many people probably do that without calling it neurogenic inhibition.
Mm-hmm.
But I know through dry needling, through manipulation, repeated motions, it's like you're always getting those quick changes. And what explains that? Maybe it's hard to tell in the research because a lot of it's subjective. But yeah, I think I use that all the time too.
Mm-hmm. Yeah, it's pretty frustrating, I think, in a sense of research, just because I don't know that we have an ability to test it, or I think the changes that we're getting could be due to something else that we completely don't understand. But we haven't found a way to be consistent with it.
And I wonder if a handheld dynamometer for manual muscle testing or something, or muscle strength, force output, a before and after.
Possibly, yeah. But again, we wouldn't know for sure that that's neurogenic inhibition or that it's what we think it is. Mm-hmm. So it makes it very difficult.
Absolutely. Brian, you know what you're getting into this month?
Yeah, I'm going to be talking a little bit more about the low back pain in the athlete. Specifically, I'm going to talk a little bit more about gymnastics. I've been consulting in a gymnastics gym for about 8 months now, and we've had so much low back stuff prior to when I came in. And there are some things that I want to talk about from a return to play guidelines as well as screening out stuff. And I'm also talking about that a little bit more because I'm coming out with a course this month, the sports assessment for the orthopedic PT. And in that, we're talking about low back pain in the athlete in general. And there was a research study that came out recently that was talking about actual return to play guidelines. And that I think that's one area that a lot of us are interested in, but we don't really have a lot of information on in school. So, and even in residency, there was not a ton of that in residency. There was some things that were touched upon, but we've gotten better over the years, and we've really learned more about loading up the low back pain athlete again, especially after spondylolisthesis and things like that. So that's what I'll be talking about.
Hey, in general, from working with some gymnastic athletes, is it hyperextension that you're trying to curb, or is it the quickness that an athlete moves into hyperextension, or what's the main thing that you see, or is it just all across the board?
Well, I think it's all across the board, but I think what I see the most is more of a movement pattern issue, meaning that when I screen out these hypermobile athletes, generally, many of them complain of tightness to me first, right? Many of them complain of tightness, or they're stretching all the time. They can't improve their splits, whatever it may be. And most of the things I see with them is micro instability as well as movement pattern problems, meaning that they're moving from their lumbar spine when they're doing a backflip versus their hips. They're not getting any hip extension. So that dissociation, that lumbopelvic control is the biggest thing I see with these athletes.
Awesome.
Yeah, I think it's interesting because it sounds like, at least that last description that you just gave, it ties very similarly to like Saarman's lumbar extension syndrome, where there's a lot of that hip tightness contributing to almost excessive or hypermobility, relative hypermobility in the lumbar spine.
Definitely.
Yeah, I think the tricky part is then you have your pain science people who would say, okay, this is a hip tightness that doesn't cause pain. Well, I think it's that repeated overload in a high power, high velocity manner that the body just senses extra stress and maybe a decreased efficiency there. So then that over time kind of presents as what would be pain then. But it's hard. Like we're talking about movement impairments, which is a touchy subject in the pain science world. So, but I think it's mixing that. It's just when someone's not moving efficiently over and over again, the body registers that as an increased threat.
Totally. And then gets used to that. So whatever school of thought you come from, I'm more biomechanical in nature just because of how much I've seen with that and coming out of USC. But I do understand and respect the pain science part of it, but we can't ignore the overuse part, like you said.
I completely agree. And then I'm going to be talking about repeated motions. And I know Chris is coming out with a workbook on repeated motions soon. And I am specifically going to be talking about repeated lumbar extension of the spine. I just see so many people who have limited lumbopelvic extension, and how that really, I think it's more of they have a sensitivity to extension in their low back, and that sensitivity over time leads to chronic pain. So I'm going to be just hitting a whole bunch on why do repeated motions, what are repeated motions, and then really like what's the dosage that you should be doing. Do you guys have anything else for low back pain? It's probably the most common thing that I see in my private practice. Even if it's not their complaint of pain, they probably are having lower extremity issues because of a lumbar problem. So I think this is going to be an exciting month.
Yeah, I know I personally, over the last couple of years, I have looked exclusively at lumbar spine for so many of my athletes because I find that is a significant issue with so many of them. And even the ones that have knee pain or whatever it may be, I am looking at their lumbar spine significantly, especially my basketball guys. I look at that stuff so much because it plays such a big role in how they're moving. So, and I think I learned a lot from you guys as well, just even from a manual therapy perspective, a nervous system perspective. That has played a huge role in my practice. So I think it's something that we all are pretty interested in and we'll be talking a lot about. So, I think this is going to be a good month.
Absolutely. Chris, any final thoughts?
No, I know that this is probably the same as you guys, probably my most commonly treated body region, not just for specific diagnoses in there, but for the fact that the lumbar spine often will almost amplify symptoms peripherally, such as like individual knee pain might have some saphenous neural, adverse neural tissue tension as well. But it's always something that we kind of keep our eyes on. So love talking about it.
Yeah, likewise. And for all the new grads out there, I would say when in doubt, if you're having confusion or questions on where to go with a complex patient, start with the lumbar spine or start with the spine in general, and then don't overcomplicate it. Just see which movements hurt. And then from there, we get way too complex in our examinations. And I think the more that we can simplify things, the better. And
I would take it even a step further. Like I wouldn't even worry necessarily about pain. In that sense, just look at how they're moving in that area, look how much they're moving, just because I can't tell you how many patients I see that I've asked, like, oh, do you have any back issues there? And they say no. And then later during the evaluation, they actually start talking about pain in their back or how they used to have some back injury. So just, I think, getting a better sense for how they move is what I like to keep my eye on.
Yeah, completely. All right, well, continue to follow us. Continue to follow our Insider Access page too. I know Chris a few months ago posted a video on the neurogenic inhibition with a specific case study. So we have tons of information coming out on the low back and even more information available on the Insider Access pages. So thank you.
Thank you.